We diet, exercise, or even have surgical procedures to lose weight, but how well do they work? And how can we keep weight off that we've lost? Bringing balance to obesity tonight, On Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. When we were growing up, there were usually one or two kids in our class who were overweight. Today, according to the Centers for Disease Control, childhood obesity has more than doubled in children and quadrupled in adolescents in the past 30 years. The percentage of children aged 6 to 11 years in the United States who were obese increased from 7% in 1980 to 18% in 2012. And the overall percentage of adults who are overweight, including obesity, is 70.7%. We'll address this epidemic and your questions after this. First, let's take a look at this week's Prairie Doc quiz question. True or false, people who have lost weight through Weight Watchers, Jenny Craig, TOPS, or other weight loss programs will usually keep 30% of that weight off after 5 years. True or false? Viewers who call in the correct answer will be entered into a drawing to win a signed copy of our book, The Picture of Health. Each of my essays, originally written for this show, comes with a wonderful accompanying photograph by Dr. Judith Peterson. We will announce the answer and the winner at the end of this show. Remember, you only have 10 minutes to get your quiz question answer in, but you've got an hour to call in any medical question about obesity, and we will take them as they're called in or sent to us via Facebook or email. Call in questions to 1-888-376-6225 or send us an email to the address on the screen. Joining us tonight are Dr. Mike Davies, Senior Medical Advisor in the Office of Veterans Access to Care of the Department of the Veterans Affairs in the Black Hills and Washington throughout the United States. Is that the correct name?
That's correct, yep.
And Dr. David Fromm of the Rapid City Medical Center, a general surgeon and a surgeon who addresses the issue of surgery for obesity. So let's start with you, David. What got you into surgery for obesity?
You know, it was an interesting field. When I came out of my training at the University of Iowa, I had an interest in doing advanced, minimally invasive surgery, which would be laparoscopic. And I loved to do what we call foregut procedures, which is procedures of the esophagus and the stomach and the
foregut.
Foregut.
Upper GI.
Upper GI. And, you know, naturally there is a need. And in Rapid City, you know, I was asked, you know, would you champion this? And I said, well, let me give you some time, and yes. And it is, it's very addicting, it's a practice. I love the practice. You know, people are excited to come see you, and they're excited to come see you when they're done.
And commonly they have a good result.
Yes.
And is how much of your practice?
I'd say it's probably 30 to 40% of my practice.
And you're originally from where?
From Rapid City.
Rapid City originally,
Yes.
and you're now still in Rapid City.
Still in
Your
Rapid
dad
City.
was a general surgeon
He
as
was,
well.
yes.
So you know, they talk about general surgery being one of those most sought after and needed specialties that people are not generally doing anymore. And we need more general surgeons. What's your comment on that?
Well, you know, people would always say if you're on a deserted island, you could pick one medical specialty to be with you, it'd probably be a general surgeon.
I would say an internist who happens to know how to cut.
Yes.
As long as they have
Yeah.
instruments, right?
Yeah.
You got instruments. And I would say that the very best general surgeon is an internist who really, by heart, knows the physiology and the metabolism and all of the medical problems that can go wrong when you do surgery.
You're right on. I think you have to have a good understanding of the physiology of the body, and you have to be able to apply surgical science to that.
I've often thought I might have done it different. I would have been a general surgeon. It's a wonderful field. Mm-hmm. So Mike, you and I have known each other for 30 years.
At least. Yeah, it's been a wonderful time.
It's been a great watching you go through this, and now you're the head of outpatient VA system throughout the United States.
That's a little grandiose. Not really. There's a lot of people in the top bureaucracy in VA.
And
but
you're
throughout
part of that.
I'm part of that now. Yeah, and I would have, look, we were talking earlier, I never would have guessed VA would have been this exciting of a career. I started out as a hospitalist at VA Black Hills for 6 years and then kind of went in through the leadership and administrative track through the rest of my career. I was the chief of staff there in Fort Meade and Hot Springs in the CBOCs for 14 years, and then kind of moved into a national role for the last 10.
They picked you because you're such a mean guy. I think that's
I'm
it,
sure
isn't
that's it. Yeah, right.
So as an internist,
Yep.
obesity is a problem that you see often?
I'm also a primary care provider. And so actually through the years, as we've seen that with this epidemic of obesity, you know, all of our patients are getting heavier over time, certainly as I look back. And I have to say that I have an interesting family. My wife, who actually works with Dr. Fromm in his practice, has 2 doctorate degrees in nutrition. And we talk about this stuff all the time. And then we have a son who's also a bariatric surgeon. So,
Oh, is that right? I
yeah,
didn't know that.
Yeah. So there's lots of talk about the latest developments in our world.
So it's interesting that the reason that this particular circle of people came together on this topic was because your wife invited the 3 of us to be on a panel.
Right.
Tell them a little bit about that story.
Yeah, so she took a stint as the president of the Dietetic Association in South Dakota and arranged, you know, interesting, the meeting around the topic of overweight and obesity, which is, as you said, such an epidemic and of common interest, and we've got to figure out, you know, what we're going to do about this, right, as a society. And so trying to get some more exposure, I think, to the issue.
And so we each had a chance to give our spiel.
Our
It was
spiel.
kind of interesting, and I thought really it changed my thinking a bit. I did write a chapter in a surgical text. It's internal medicine for the surgeons out of Emory, led by Michael Lubin, an old friend of mine. And then we did it a second time, and the chapter I had was medical problems in the obese, in surgical problems for the obese. And actually the end of the chapter was, at the time, 35 years ago, was to say it's too early to start recommending general surgery for obesity because
Right.
we didn't know what we were doing and people were dying and there was a lot of problems with it.
Right.
But before we go into that, I want to start with why do we care about obesity? I know, okay, there's an epidemic, big deal. Why does it matter? Dave?
Well, if you look at all the things that are associated with obesity, you know, you have higher risk for heart disease, stroke, kidney disease, certain types of cancers, earlier age-associated dementia, just chronic pain. You know, people come in with achy joints, achy backs. You know, if you think about it as a society, we're always... Sleep apnea. But we're always treating things sort of after the fact. You know, you're in the emergency room with the complication, we're treating you then. You know, and the idea for treating obesity is this could be something that we can modify before people ever get to that point.
You know, you look at the diabetics in particular who are very, very overweight. If you can get them to lose weight, the diabetes goes away. It's just amazing.
Yeah, from an internal medicine standpoint, we always used to look at, I would guess, our diseases through the eyes of hypertension. Oh, and by the way, you need to lose weight, right?
Yeah.
Or diabetes, and if you lose weight, then your diabetes will get better. But, you know, it's interesting, one of the aha moments for me in this whole world of obesity is we probably need to flip it. And we probably need to say obesity is probably the core issue. And then there are a number of associated, you know, comorbidities, if you will, or diseases that come with obesity. And the interesting thing is you can pick a medicine to treat any one of those diseases that will make your weight higher or lower. So us providers have to be thinking about what the options are for meds and pick the one that's not going to make the core problem worse.
Right. I mean, there's certainly some medicines for diabetes in particular that enhance the weight gain.
Right.
Insulin being one.
Right. Well, and hypertension and contraception and psychiatric issues and seizures. It goes down
It goes
the
on
list.
and on and on,
Yeah,
doesn't
yeah. It's a big deal.
So there is no question about it. It's a good idea to try to get people to a normal weight, or try for individuals to get themselves to a correct weight. The problem is, it's a difficult challenge. It's much more difficult than we really understand. How do we know, or what is the definition of obesity? And I mean, for example, you need to have a certain weight before you're going to take a person to surgery. There's some people who are relatively thin yet, and that they want to be thinner yet.
Yeah. So there's two ways to think about it. You know, there's a criteria that's established through the National Institutes of Health, and so they look at factors such as your BMI. And the BMI is looking at your weight in kilograms, which is 2.2 pounds is 1 kilogram, and then you divide that by your height in meters squared. And so it's a way to kind of compare apples to apples, oranges to oranges. You know, you may be 250 pounds and 6'5", and that's vastly different if you're 5'2" and 250 pounds.
Yeah, it is.
So, you know, you talk about a BMI. If your BMI is greater than 30, you're you're obese. If your BMI is 35 to 40, you're morbidly obese. And we usually say 40 and plus, you're grossly morbidly obese, or severely morbidly obese. But, you know, if you talk about obesity, obesity can be philosophically more than that. You know, people question the whole idea of the National Institutes of Health criteria.
Right.
Obesity could be excess adipose tissue plus the effect that that has upon your system.
Right. Now, I mean, we're talking that definition of BMI, but I know for a fact that men or anybody shaped like an apple with the Dunlap disease, just huge abdomen fat, are at higher risk for heart disease and vascular disease and a lot of the problems associated with obesity than the people, classically a woman, who's pear-shaped, and they're all in the legs. And in fact, those people who are pear-shaped, the only way they'll ever lose weight is to make them pretty sick as a rule. And that's been my off the side. Any response to that?
Well, I think there's, it's not as simple as looking at somebody often, right? You can look at somebody and think that they meet the criteria for obesity, but they may be big bone, they may be tall, short, etc. They may be different shaped, so we can step on the scale and get more information and see what your weight is. Or you could do your body mass index, like Dr. Fromm just mentioned, you know, which gives you a better understanding of it. Or there's even more sophisticated tests nowadays.
Oh, yeah.
You could do the DEXA scan, right?
And see what percentage of fat.
See what percentage of fat. You might have a lean body that's all muscle, but be technically overweight. And so you gotta be thoughtful about making that diagnosis.
Right.
Because once you make the diagnosis, the new thinking is that this is a disease. We used to think, right, that this is a problem with behavior maybe, or an unlucky genetics that you got. But obesity now is thought of as a disease in itself, which is kind of a new model,
Yeah.
I would say, than I grew up with anyway.
Well, the manifestations of this disease
Yeah,
are all these other
right,
chronic conditions that are certainly life-threatening.
potentially, yes.
So let's talk about the causes. You touched on that. I think that's the magical question. What are the causes of obesity? It's your turn.
Multitude. You know, people would ask about it, and I heard somebody discuss it this way. They said, what is the cause of obesity? And you could say, is it your genetics? Yes. Is it overeating? Maybe. Is it this? But they said, compare it to the same way. How do you say that you are at risk for heart attack? Is it high blood pressure? Is it smoking history? Is it genetics? Yes, it's all of the above in each one of those. So for obesity, you can't say it's just one thing. It's a combination of a lot of different things.
Right. I just got a nudge. We need to kind of go in this direction.
Sure.
Losing weight is a difficult process, but keeping it off is a moving target.
I've been fighting weight since literally young adulthood. I've gone through a number of weight loss programs. I've always been successful in terms of losing weight. I've had a much more difficult time maintaining that weight loss for any reasonable period of time. So keeping it off for a year is sometimes been plausible, but maintaining a weight loss for more than a year, year and a half, 2 years has been very difficult. I've also undergone gastric bypass surgery, and that was really something I did about 10 years ago. But I was at a point health-wise where I needed to do something or the quality of my life was going to continue to deteriorate with respect to those associated health risks that go with being overweight. For me, it was a good decision. Some of the comorbidity issues like diabetes and high cholesterol, sleep apnea, general fatigue, growing joint issues, all of those literally disappeared as a result of the surgery. So for me, that was not something I did for cosmetic reasons. It was something I did for health and wellness. But I continue, even having had that surgery. It was very successful in terms of achieving a weight loss. But over the intervening 8 years, you know, my weight has slowly crept. And so I still need to be mindful and to be conscious about that. But for me, the surgery helped me become more conscious and more intentional in my decision making. The focus today is much more on the pursuit of wellness and health and fitness than on weight per se. And so, you know, you're starting to see concepts like mindfulness. You're starting to see concepts like self-compassion, so that losing weight, hitting a target on a scale is not necessarily the preferred goal.
Thank you, Dr. Papini. What a wonderful gentleman, and the head of our arts and sciences here in Brookings, SDSU. This is your show, and your questions are key to our show discussion. We've got a few. We need more. It's your show, so call in your questions about obesity to 1-888-376-6225, or send us an email to ask@prairiedoc.org. So please, give us your questions. So that was an interesting interview. What's your response?
Well, you know, this is the new most effective treatment for obesity, is what Dr. Papini had. I mean, that surgery has dramatically improved since the 35 years ago when you wrote that book chapter.
Yes.
And it is probably going to be more and more sought after because it works. And it works because it intervenes in a way that other treatments we've tried over the years have never worked. Diet and exercise, as we started the show with,
right,
which I'm sure we'll come back with, you know, is sort of a starting point. That's foundational, right? But when you get to a certain point, the surgery changes the way your body functions. And it really does work.
I mean, we talk about the causes, and you said it's myriad, right? But I know that people, there's something that happens at adolescence, just as and sometimes people gain weight then. There's something that happens when a woman delivers their first baby, and then they seem to gain after that baby, then they could never, and then they may gain again at the next baby, and then they gain into the next baby. Then there are those people who will gain weight 5 pounds a year, you know, or 3 pounds a year. But it's just, you know, year after year after year after year after year after year. So, I mean, you can see it, and it seems to me that when you gain weight, your body resets itself to that weight and says, this is what I'm going to do, everything I can to maintain that weight at that level. Do you agree with that?
Yeah, so I want to talk about that because the way we used to think about obesity was like a bank, right? I remember doctors, mentors of mine, right? Probably me too. You'd go in the room and you'd say, well, it's like a bank. You know, you could, every time you eat, you make deposits in this bank and you gain, you know, energy that's stored right in your body as fat. And then when you exercise, you take withdrawals. So the idea is to balance your deposits and withdrawals.
Yeah.
But
it doesn't work.
But it turns out it's not like that at all. It's really more like a set point, like a thermostat. You set the thermostat in your house at 70. If a storm comes through and it cools off and your house cools off, your furnace heats up and brings it up to 70, right? If you have a heat wave that comes down, then your air conditioner kicks on and brings it down to 70. You have a set point. And it turns out our bodies probably work more like that set point and defending that set point, trying to get back to that set point, than they do like the bank model.
Yeah, and the question is, why does it allow itself to gain, but doesn't allow itself to lose? And I mean, why does that set point
Yeah.
occur?
That's a good question. I heard this talked about this way, that it's the idea, and some people dispute this about the thrifty gene analysis, and people would say that the human body has evolved for millennia for the ability to survive famine and starvation.
Right.
And so our body is designed to keep whatever weight or whatever energy. You have to talk about adipose tissue. Adipose tissue is stored energy. Your body is saving it for that time that will happen that will never happen. And
In this day and age.
So yes, and so it is. And so your body is designed to maintain that. As soon as you lose weight, your body will do things to bring it back up. People talk about, the willpower issue. Why do diet and exercises not work? Well, you would say, well, it's the willpower of the person. You lost weight, but you didn't stick with it. You went back to old habits. It's a food addiction.
Yeah,
But it's
blame,
not.
guilt. I mean, we all do it.
Shame.
Shame, guilt, and what do we say to a person who is heavy?
Make
Yeah.
fun of them.
Negative,
yeah,
negative,
yeah,
negative
yeah.
comment.
Yeah, it's wrong.
Yeah.
Oh, and you're shameful. I mean, how can you eat so much?
Yeah.
There's some data to say that heavy people eat less than thin people.
People that come in my office, they have things down. They have a chart, and they will tell me exactly when they eat, how many calories. They went to the gym and they burned off this many calories for this. And they're frustrated because they're like, I'm doing all the right things and I can't lose any weight. Why is that?
But it's complex, and I like the way you started with this. If you look at somebody's chart over their lifetime, you'll see you gain weight during adolescence and adulthood, but then you have different life events, different social things that we think must change that set point, that thermostat.
Right.
And so one of them is age. You tend to make your set point go up a bit with age. We know that, right? But one might be something like eating a bunch of calorie-dense, high preservative foods, carbonated foods, more than you need. Maybe your body senses that as a way to reset the set point. Maybe you have a traumatic event, and maybe your body senses that. Maybe you're around a bunch of people, whose weight is much higher than yours. Maybe that has something to do with our brains in resetting that set point. There's a whole bunch of things we're just starting to understand, I think.
Back in the 70s, there was some solid studies where they paid college kids, to overeat. And they found that they didn't like it, they didn't want to stay there, they didn't want to continue, they got uncomfortable, and then when they were no longer paid to overeat, they came right back to the same set weight.
Yeah.
Isn't that amazing?
Yeah.
Of course, in my case, it was 5 pounds more than,
Well,
than it was before. I mean,
the same thing with The Biggest Loser, right?
what's happened with those?
The Biggest Loser in 2009, it was a dramatic finding, really, that we had people that lost on average 120 pounds. In season 9, or 2009, in The Biggest Loser, 14 of the 16 people who were studied had lost on an average of 120 pounds, but after the show was over, they went back up to where they were before. Amazing.
That's right.
It just
so we
bounces
don't understand the cause, really. I know that we weigh, as a rule, we weigh what our biologic parent, the twin studies and the adopting studies from the Netherlands show, you don't weigh what your adopted parents weigh, your environment. You were raised the whole time with all these other kids. You weigh what your biologic parents weighed.
Yeah.
So there's a huge genetic thing. But if that was all that there was, why are we gaining weight? People blame the fast food. What's your take on the fast food?
I think that there has to be some component of that. If you look at the history of the U.S., and they talked about in the 50s, when the American Heart Association came out with the diet, which was the low-fat, high-carbohydrate diet. Right. And they would say that it didn't do anything. And you could see from the 70s that obesity ballooned from that point. And people talked about it and said, maybe fat isn't making us fat. Maybe it is carbohydrates. Maybe it is sugar. Maybe it's this craving for things that are sweet, and then within our diet that we get used to that. I told Mike that when I was a college student that I was lucky. I traveled to China. I was in China for a short period of time. And this was back in the early 90s. Yeah. And it was probably a novelty to see somebody from the United States. And I was studying economics at the time. We go to all of these factories and people would be, oh, these Americans are here. This is special, and they make us a cake. It looked like this beautiful, tasty cake. and you took a bite of it, and it was disgusting. You know, it did not taste sweet at all. You know, and it's just, it's just everything, even candy, everything there was not sweet. And it was weird is that, you know, we were just over there for about a month and a half, but by the time that you were there, you got used to it. And we came back to the States, we landed in LA, I went to McDonald's because I had had a Big Mac for a while. And the first bite of it, you're like, this is just way too much. And it's sort of that there was sort of a perceived taste. And maybe in the United States, maybe we've gotten used to things tasting too sweet.
But I mean, there's no question about it. The big deal was the realization that it isn't the fat in our diet that has caused obesity, it's really the carbohydrates. Or at least what they've done is they did a comparison between a low-fat diet and a low-carbohydrate diet, and the people who were in the low-carb lost more, felt better, cholesterol dropped lower, everything was happier. They were more successful than the low-fat, but then after a year it was the same. And so they said, well, neither works.
You know, there's been so many books and so many diets, and the bottom line is they all work about the same.
Yeah.
They work for a while, and then you kind of bounce back to your set point.
Right.
For most of them, or most of the way to the set point, not all the way. I mean, I don't want to say that there's no benefit to diet and exercise, because there is some, right? It's just not as much as we want.
I think the key is with exercise. But let's talk about surgery, because, I mean, right now, you've got a video we'd like to kind of show right now, and then have you talk through it as we do this quick little video of what surgery is this going to be?
So this is a sleeve gastrectomy. So this is a surgery that has been around for a while, but it's probably become more popular from year 2008 and beyond.
Okay, you can start it anytime if you've got it up. Okay, so what's going on there, Dave?
So what you're seeing is the, probably looking from the belly button up towards your chest.
That's the liver?
There's the liver there that we're elevating. And so we put a little device just to get what's called the left hepatic lobe out of the way. And so to the right, you're seeing a little fat pad that overlies probably the bottom part of the esophagus, top part of the stomach. This is an area we call Belsey's fat pad, named after Dr. Belsey. And the reason we look here is to see if there is some degree of what's called a hiatal hernia, where your stomach gets pulled up into your chest. And if we see those, we like to fix those. So we're just removing that just to get it out of the way. Now we're looking at the stomach. What you're seeing to the left is the pyloric valve, the one-way valve at the bottom of the stomach. We just put a mark on what's called the greater curvature. This fatty area here is called the gastric colic ligament. There are blood vessels that run from that aspect to that part of the stomach, and so we need to remove that to do the second part of the operation. So essentially we open that all the way up, all the way to the top of the stomach.
So the stomach is so tied to all that adipose tissue.
Yeah. So
Do you see that much fat tissue normally in thinner people when you're doing general surgery?
You can. It's surprising that there are people that are fairly thin that still will have a lot of that's called visceral fat, fat around the organs. And there are some people that are quite large and they may not have that much. But I'd say on average, people when they're overweight, they tend to have more visceral fat.
So what are you doing? You're releasing the stomach from visceral fat.
Yeah, so just the right, you don't see in this picture is the spleen. These are called the short gastric vessels that run between. And so this is the top part of the stomach, which is called the fundus.
Now
So
you don't hurt the spleen or anything by
No.
cutting off the vessels that run between the stomach and the...
So as you come through here, you're flipping up the stomach, and you'll start to see behind the stomach, there's the pancreas. We'll come into view here, right here. Here's the pancreas right underneath that. And you'll start to see kind of the part of the stomach that's here. So what we'll start to see is there is a tube we call a bougie, and it's a certain diameter. And that's what we use to calibrate the part of the stomach that we're going to remove. This device is called an endo-GIA stapler. Actually, it was invented by the
So the
Russians.
bougie is going down the throat,
It
right?
goes down the throat and we
Into
put
the stomach from
into
the
the
inside.
stomach. Yep.
Okay.
Okay,
And so-
so there's a bougie on the right that's inside the stomach is what...
Well, the bougie would be just to the left, and we kind of use that to calibrate the size of the stomach that we want to leave behind.
Okay.
And so the part of the stomach that we're removing is the part that will stretch. So the simple way to understand this, which I don't think is necessarily correct, but the simple way to understand is you're removing the part of the stomach that typically would stretch to accommodate a meal. But in reality, what we're doing is we're creating a certain amount of pressure within that portion of the stomach, and that will have an effect. You know, people also talk about all of these hormones within the GI tract, and ghrelin is one that has become fairly popular. in
Ghrelin,
stress.
Ghrelin.
Ghrelin or ghrelin.
Ghrelin.
Yes. And so ghrelin,
Okay, we're back to the video.
yeah, ghrelin, we think, if you look on the right side of that, that's called the fundus, and we think that that part of the stomach is the part that produces that hormone. And that hormone, when it's at high levels, typically people report that they feel hungry. So when you're removing this portion, a lot of times when people have this procedure, they usually will say, I just don't feel hungry. Sometimes they say, I know I need to eat, but I don't feel like I have to eat.
So the little known fact is this really may be a metabolic surgery.
Yes.
Yeah, you may be removing physically the stretching part of the stomach, but you may be just removing the part that makes the hormone that drives hunger.
That drives hunger, absolutely.
Ghrelin. Now, what's the counter of ghrelin?
Well, the counter of ghrelin, it would be, there's a lot of different hormones there within the GI tract, but ghrelin is just one of them that plays a role.
All right. Now, what are we doing up here now? Oh,
So
we're not on the camera.
that's all right. So the last part of it is just that, once we remove that portion of the stomach, that part will come out. And so with the sleeve gastrectomy, people ask, is that part of the procedure permanent? It is. That part of the stomach does not grow back. But by removing that part of the stomach, I always tell my patients it does three things. One is that it decreases ghrelin levels, which does typically lead to loss of hunger. That's a big thing for people, is they say, I feel hungry all the time. It's great, I don't feel hungry anymore. The second thing that it does is that it creates, in my opinion, a certain amount of stretch upon that part in the stomach. It's not a volume thing per se, it's probably a stretch thing. There are mechanical receptors upon the stomach that have feedback through a nerve called the vagal nerve that goes to a portion of the brain called the brainstem. That interacts with a portion of the brain called the hypothalamus, which is sort of where we have this thermoregulatory control over our body.
Right.
So I see a lot of patients that come back and they say, you know what, sweet stuff just doesn't taste the same. This doesn't taste the same. I had a lady that I saw for a 1-month follow-up. I asked, how are you doing? She said, well, I had a ding dong, one of those Hostess things.
Yeah.
I said, well, I know you're not supposed to be eating that. She said, yeah, I ate about half of it. It didn't taste good. I threw it away. Well, it's interesting that their
It
taste,
wouldn't happen before,
that their
right?
taste will change. The last thing that we talk about this is that, it is a metabolic procedure in that it will change other things too. Since there's less stomach to stretch, the amount of time that food stays within the stomach is less. So food is kicked out into the small intestine at a faster rate. And there is the second component, I'd say the third component, of this procedure, and that if you decrease the intestinal transit time, the amount of time the food stays within the small intestine, that will change more hormones. There's probably 20 different hormones that will change, but people talk about
There it is.
glucagon-like peptide 1, CCK, or cholecystokinin, amylin,
PYY.
peptide YY.
Leptin.
Leptin.
Yes.
Leptin, that's it.
That's a big one.
What does the leptin do?
It comes from the fat cells, and that also influences your hunger, right?
Yeah.
Yeah.
So now we're not going to show any more of that fun little romp through the inside of your gut. I love that picture. That was wonderful. Thank you for doing that for us. But the question is, do you put a sleeve over the stomach so it doesn't get overexpand, or what's the sleeve thing?
So the sleeve is removing the part of the stomach that will stretch. So the part of the stomach that will accommodate a meal is that portion that's removed. And you would say, well, the stomach could hold anywhere between 1,500 to 2,000 cc's, or cubic centimeters. Right. And you're reducing that down to 250, let's just say on average.
So you're not putting in a device or anything. There's not a band anywhere. This is not the band procedure.
No. So your body's own natural tissue is there. But the idea behind it is that you're not necessarily restricting the patient. A lot of times in surgery, there's always this idea of restricting. I want to eat, but I can't because I can't get enough food in my system.
Right.
The idea is we're not restricting, we're changing your perception of hunger. Your hunger drive is less, the way that things taste is less, and your body is losing weight through a way that you don't quite understand. The idea, go ahead.
Go ahead. I was going to ask you, is that the one procedure you do, or what other procedures you do for obesity?
No, we do a multitude. So, the simplest things that we probably do is a gastric balloon.
Gastric balloon.
Gastric balloon.
Which you blow up in the
stomach.
stomach.
So you put a balloon inside the stomach, and like I said, there's been some popularity with that. People like it because they say it's a non-surgical procedure. There's more providers that can do it, but the reality is there's probably a very slim portion of the patient population that I would consider a good candidate for that. There's the gastric band, which is really popular, and I think the gastric band still has a role, but the gastric band is popular for reasons that it probably should not have been popular, and it was placed in patients of all different sizes. It's probably better for lower BMI patients. There's
People
the-
aren't so heavy.
Yes. There's the sleeve gastrectomy, there's the Roux-en-Y gastric bypass, there's the duodenal switch, which is essentially what we just showed, the sleeve with the bypass downstream of the stomach.
Okay. And you do them all.
Yes.
All right. Let's just jump into questions because we've got a number. How vigorously can a person over 65 exercise? Mike?
Well, they can exercise as vigorously as their body will allow. I mean, they should, if they haven't been exercising for a while, see their doctor and make sure that they are up to it, you know, but you can get your heart rate up to 120 probably, as long as it's safe. You know, now if you're having symptoms, if you're having joint pain, that might hold you back. Certainly if you're having chest pain, you want to get checked out before you do this. If you're short of breath, get checked out. But once you're checked out, I mean, start slow and don't jump right into it. Start slow and then get to it, because that really helps your mind feel better. It helps burn some calories, and it is it's a very healthy thing to do.
Are you still jogging?
No, I have to say.
You and I
I'm
have
not.
jogged together many
Yes,
times.
we have. Yeah, walking, I would say.
There it is.
But
And I
it's
like the
better than
idea of,
nothing.
there's some studies that say that if this person can walk 30 minutes a day, just at the rate they're comfortable,
Yep.
that you get the much of the benefit that you get from anything.
Yeah, whatever exercise you can do and still talk to your buddy
Yeah.
is what's recommended.
Don't overdo it and bring on a problem. Don't ignore problems. If
Right.
you're starting to get into trouble, be careful, back off, give your knee a chance to
Right.
re-heal, whatever it might be that's running into it. Does obesity, is it related to the high consumption of fructose corn syrup?
Wow.
I mean, that's the big, you
Yeah,
know,
yeah.
people love to blame the Coca-Cola.
Well, I mean, pick something to blame, right?
Yeah.
Non-saturated fats or polyunsaturated
Yeah,
fats,
yeah.
right? Corn syrup. I don't know, sometimes carbohydrates, right?
Yeah.
And there's a million different kinds of diets out there that eliminate everything and go back to the caveman diet, right? The paleo diet, and eliminate everything else. The bottom line is it's calories, you know.
It's
I
calories,
think.
isn't it?
It's calories.
I really like the idea of teaching people to count calories.
I'm going to disagree with you. I'm going to say that there may be some validity to that. You know, because you think about
Ah,
it, that no,
little
I will, because,
disagreement.
you know, it is probably the perceived sweetness of food. It is the amount of sugar that we probably have within our diet. And you kind of wonder, why is fructose corn syrup in everything? And it may not just be fructose corn syrup, but it is an easy filler that can be placed into that. I think, again, the American diet, we're used to things being so sweet. We have artificial sweeteners to make things sweet. It's the perception that we have to everything taste a certain way. So, yeah.
I think that's a fair
Or maybe
argument.
you don't make your own food at home. You know, you go to the fast food place that packs food with things that end up with more calories.
Yeah.
Right.
Yeah.
And of course, you sell more fast food if it tastes good.
Yeah. I know that there's high fructose corn syrup in everything. I mean, in Campbell's tomato soup. I mean, it's
Yeah.
the sweetener that the government has encouraged us to do because they have manipulated farmers to raise corn and blah, blah, blah. I mean, there's...
Maybe.
So, good questions. And the answer is, you and I both think that carbohydrate and fructose corn syrup are bad, but I think the bottom line is calories is what matters. And if
It
people,
turns into energy. And
Right.
that energy.
One of the things, you know, I always just tell people that, you know, it's kind of like the idea of the Pringles potato chips. And you say, what's different about Pringles potato chip? Well, there's probably a lot of stuff that's added to it. But it's even candy. Just watch little kids, or just even yourself, just have something that's sweet. Know that there's a bag of it. Eat one and see if you can resist eating more. I think there is something, again, with the natural hormones within inside of the gut. You know, you think about it, cholecystokinin being one that is secreted by the duodenum as far as a load.
Right.
It responds to fat and it responds to protein, but there's no response to carbohydrates. Very interesting. So it could be that just having fat or having a little bit of protein in your diet, which is essentially the paleo diet, does tend to eat less calories or less food intake because you tend to feel full.
you know, there's these weight loss programs where you eat their product. And there's a profile diet that's available right now, for example. People lose weight very readily on it. It's no carbohydrate. It's protein and fat, and then your body has to take the fat and break it down into carbohydrate because we have to have carbohydrate to feed the brain to keep going. And so but you can't sustain that forever, which you can.
Right. So the dietitians would say, I think, and I can hear my wife Sue
You
in
can,
my
she's
head,
she's
you
screaming right now.
You don't learn anything from that. right? You buy something, you do the easy fix, you eat the meal because you don't have to think, you don't learn anything. Part of this is becoming mindful about not only what you're eating and how many calories are in there, and maybe where is the hidden, fructose and corn syrup in there,
There it is.
but also what are the portion sizes? Are you cooking? Are you going to the grocery store and eating? Is there, fiber in this diet? I think we got to get back to the basics when
Right.
it comes to eating.
And
I'm going to be really critical of that. I'm going to say, what's different between that and the Atkins diet?
It's
the
the
same
same.
thing. And
Yeah.
so if you've already shown the Atkins diet will lead to that weight loss for a year, but it loses its effect after a year, why reinvent the wheel?
Right.
It seems like there's so many gimmicky things that are put out there in order to give people a sense of false hope that, again, if I do this diet or if I do this, this is going to be the magic thing that's going to lead to this weight loss. It doesn't. So why do we promote this? You see a lot of patients I see a lot of patients in my practice that come back and you say, what diet I've had? They have 20 different things that they sometimes have tried. I've tried this, I've tried that, I've tried that.
Grapefruit.
Did it work? Yeah, it worked for a period of time and then it came back. Again, it goes back behind the science behind obesity, that you have this thermoregulatory set point. And you can't, your body conserves that. You will lose, but you can't lose with diet and exercise. It comes right back.
Right. What do you think? I think this is a question. What do you think about the vegan diet for someone trying to lose weight, specifically Forks and Knives documentary? And I don't know what this Forks and Knives documentary is. It might be. Do you?
I
either
don't
one of
know
you?
either myself, but
But-
I know
but the
any diet results in weight loss, but it does come back. Now, I want to throw in here, though, that there is one other new development, especially since 2012, and that's drugs. Right, so those of us that have been
Right.
experimenting over the years with different pills for weight loss, we know that diet and exercise is foundational. We know surgery, kind of at the other end of the spectrum, takes your appetite away, probably because of influencing hormones. There are a developing group of medications now that can potentiate the effects of diet and exercise and can help people lose weight faster and keep it off longer if you take pills that help influence your brain's hormones in terms of reacting to some of these stimuli.
I will say this, that Carrie Hegberg, the nurse practitioner who worked with me for years, had brought this up to me. She says, well, I've noticed people that are on Prozac, fluoxetine,
Yeah.
seem to do better.
Yeah.
And whenever we start metformin on people, when they have diabetes, they seem to do better and lose
Pretty
weight.
insightful.
So I've been putting people on, even when they're not depressed, on Prozac, and even when they don't have diabetes, on metformin. I put the two together, and it seems to help. And we had a number of people who had gastric bypass surgery, and after years, they're about halfway back to where they were before. Hit them with fluoxetine and metformin, and they stopped. I mean, they went down a bit and then maintain now. Now that's a cheap option. Those are cheap options. Both of them are available generically and cheap. There are new things though that are more expensive. You're talking about.
Phentermine comes to mind. That's an old drug.
Phentermine.
Or phentermine.
Phentermine.
However you want to say it.
Yeah.
Is cheap. It's like $36 a month, right?
Yeah.
It's well studied in terms of the side effect, and it's also very effective, just like those. There are some newer drugs. You got to be careful. Some of them are very expensive, but there are some new drugs that are options too.
Okay. So vegan diet. People who go on a vegetarian diet, a vegan diet, that means that they don't eat eggs and they don't eat milk, drink milk,
So-
or milk products, right?
Right, so let me stop right there. I mean, where I react to that is the word diet, right? We've got to adopt an eating habit that's mindful for the rest of our lives. Diet to me means temporary. We're going to do something for a while, fix it, and then we're going to
Go back to what we
go
did before.
to the pre-diet phase. I think the real issue is start to learn what is it that we're eating, what are our habits, what stimulates to eat. Do we get up in the middle of the night? Are we eating because of an emotional drive? Is there some medications that may be involved in stimulating that? Then start to address some of those factors and learn how to do it. And one other thing I'd like to say is this app that you can download from the internet, the name escapes me at the moment.
But a weight loss
A weight loss
exercise-
app. You can just Google them. You can get them anywhere, and they will help you keep track of how many, when you're eating, and how much you're eating, and how much you're exercising. And I think that those help a lot.
Are you thinking of MyFitnessPal?
MyFitnessPal.
There's a lot of them.
Yeah,
MyFitnessPal
yeah.
is one.
That's
That's a
one.
good one.
Yeah.
Yeah.
But I had a group of 70 plus years of age, and I'm teaching them diet and exercise program as
Yeah,
a group.
yeah,
Trying to
yeah.
do that. And the government, by the way, won't pay a doctor to lead a group. That I did it for free. I mean, that's just the way it was. They won't pay a group therapy. But this group got the energy to stay active and do physical things and to eat correctly. But one of the things we were talking about is diet, calorie counting. And I said, just take a diet diary for a week or even 3 days and measure how many calories you ate each day. And it's amazing how well they did. They really did pretty well. But the easiest way to do it is you just get, Siri, how many calories in this candy bar or that bowl of cereal or this amount of steak? And most foods in all of the restaurants have a calorie count on them. And boy, it's amazing the calories that are inside.
I have to say, I downloaded MyFitnessPal one time and tried it on myself for 2 weeks.
Yeah.
I'm not that overweight, but I wanted to learn, sort of what calories were, and it was a very enlightening experience.
Yeah.
It's like, wow, that's 2 portion sizes, not 1.
I didn't realize how many calories was in that.
Yeah.
I had an Applebee's steak, 400 or less calories, right? My daughter, a tiny little person, had a crispy chicken salad, right? Hers was 1,300 calories. Mine was 400. We really should count calories. We've got no times left. We got to run through these questions. Let's be real quick. Man from Hendricks, Minnesota wants to know, how much does weight gain affect a hiatal hernia?
It can.
It can.
You can. At the beginning of the film, I was looking for hiatal hernias, but I'd probably say 50% of the people that I operate on will have some hiatal hernia, some component of a hiatal hernia.
Yeah, so I mean, and certainly reflux esophagitis is a symptom that's troublesome.
And
Because
that
if you
pressure inside
yes.
your abdomen, that
Because you think about it, it's just a
No
contained
room.
cavity, and if you have extra pressure, it's got to go somewhere. You have natural holes, that's being one, it's going to
Pushes
push
it
it right up.
Woman from Pierre has heard drinking water with a lemon before a meal can help make you feel full. Is that true?
good strategy. It's a commonly suggested one, and it's something that's easy. Anybody can do it. It helps fill up your stomach.
Does prednisone help cause increased appetite and weight gain?
Yeah.
It definitely does,
It
and
does.
that's an underlying cause. Another thing we didn't touch on much is stress. In our society today, we have stress increases natural prednisone or cortisone, and you tend to eat more and respond to that.
And that's a cortisone
lower
thing.
stress, good eating habits. Yeah.
One question from Aberdeen, a cholesterol 242, it's my cholesterol, and began exercise and taking niacin in 9 days. Cholesterol is 180. Is this normal? How often? How about niacin?
It's a fabulous response to the niacin and the exercise. I would say congratulations, keep it up.
Yeah, so very good. And now for the winner of tonight's Prairie Doc quiz question, true or false? People who have lost weight through Weight Watchers, Jenny Craig, TOPS, or other weight loss programs will usually keep 30% of that weight off after 5 years. True or false, gentlemen?
False.
False, they don't. After 5 years, those who have regained their original weight is almost 100%. That's 0% have kept it off. It was Richard Jurgensen of Watertown, South Dakota, who answered the question correctly. Thank you, Richard, for participating. And a book will be in the mail to you soon. Do you have any questions or comments?
Well,
Very
I
quickly.
would say that was a yes or no answer, but diet and weight loss does work in helping to decrease the secondary effects of obesity, right? So if you get high blood pressure from it, diabetes from it, there's proof that does work.
I mean, I think eating less, whether you lose weight or not, is the right thing to do for your overall health,
It is.
along with exercise.
Yep. Yeah.
Forget the weight, exercise, eat right, you'll do
feel
better.
better, you sleep
You'll feel
better.
better, you'll sleep better. Niacin, I'm not a real fan of. It can cause symptoms, and no data to ever say that it's reduced heart attack or anything, but it worked for this person. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
Isn't it strange that in this era when there is an epidemic of obesity, our society seems to define beauty as thin? When there is such a difference between what's expected and what is real, it leaves people desperately in search for a solution to their problem. Add to the perceived beauty issue, several severe medical problems result or worsen from obesity, including diabetes mellitus, sleep apnea, weakness, and immobility, making weight loss as an important goal to enhance health, not just for cosmetic reasons. There seems no easy solution, not for any individual and not for society as a whole. Multiple studies show weight loss, even in highly motivated people, happens in about 30 out of 100. After 1 year, only 10 have kept it off, and in 5 years, only 1. I know there are exceptions to this rule, but in general, losing weight and keeping it off is a very difficult task. Repeated studies show that, for the most part, adopted adults weigh what their biologic parents weigh, not their adopted parents. In the case of body shape, nature wins over nurture, as it seems we are destined to look a lot like our parents. In addition, it's human nature to eat more than we need and to rest whenever we are not required to move. That's old world survival behavior that comes already set in our hard drives. However, it's a new world where too much food comes with too little effort. What's more, our hormonal and metabolic systems seem to manipulate hunger, metabolism, and activity in order to maintain or even gradually gain weight, but not to allow weight loss. Is this overweight destiny completely out of our hands? Does our hunger have to drive us to the fast food restaurant? Or could we serve our family smaller portions of a healthier fare, especially with non-starchy vegetables? Do genetics chain us to that couch? Or are we still free to get up and get moving with a daily 30-minute walk? Studies show that a heavy person in condition and eating right lives as well and long and healthy as a thin person. Bottom line, we should not set our expectations toward looking like someone we are not, rather toward living a healthier lifestyle. We should do our best to avoid the up and down and up again weight roller coaster, which can be harmful physically while worsening self-image. We can choose to realize that beauty is not defined by weight or size. Beauty is health, which comes from exercising well, eating right, and then loving ourselves for it. Well, a great big thank you to our great guests tonight, Dr. Mike Davies and Dr. David Fromm. Thank you, gentlemen.
Thank you
very
for
much.
inviting us.
We couldn't have done the show without our experts. Here at On Call with the Prairie Doc, our staff and crew work to provide honest, science-based information aimed to help you make good healthcare decisions. If you believe in our efforts providing good information in a world of misinformation and would like to help continue this quest for trustworthy, real information, please go to prairiedoc.org and click on the donate button. Any help you can give will be put towards providing authentic information to thousands of viewers. Thank you. Well, that does it for tonight. From all of us here at On Call with the Prairie Doc, until next time, stay healthy out there, people.
Moving through our world has its dangers. One false step or bad reach can send lightning bolts of pain that may stay with us for months. Muscle sprains, pains, and how he complains. Next time, On Call with the Prairie Doc.
Major funding for On Call with Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On-Call Television as it continues to open doors for important medical information.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions. Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Aberdeen District Medical Society, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications.